Assalamu alaikum wa rahmatullahi wa barakatuhu. Welcome back to the channel of Stand Medical Notes. So, we have discussed about the target organ damage. Today, we will continue the topic, and today we will discuss about the primary and secondary hypertension, and time permits the further topics. So, we know that uh, we can classify the causes of hypertension as two: number one, primary, and number two, secondary. So, number one, primary cause, which is also known as essential hypertension, accounts for 90 to 95% of the cases. Number two is secondary hypertension, which accounts for 5 to 10% of cases. Okay, the cause for primary hypertension is not known. So, as we have discussed in the pathophysiology, it is polygenic. That means it has a genetic predisposition, and patient will generally have a family history of hypertension. Whereas secondary hypertension will have a cause. Will have a cause. So the most common cause of secondary hypertension is the renovascular cause. Renovascular cause is the most common cause of secondary hypertension. Renovascular cause. And second, other than renovascular cause, the second most common cause of secondary hypertension is, you can label it as B. It is the endocrinal cause. Okay, just remember the most common cause of secondary hypertension is the renal and renovascular cause. And primary hypertension, which is also known as essential hypertension, doesn't have any cause. It is genetic in nature. Patient will have family history. Whereas in secondary hypertension, patient will not have any family history. So when we should suspect the secondary hypertension? If a patient comes to you with hypertension and you have diagnosed the hypertension according to the criteria. So when you should suspect a patient coming to you with hypertension, the secondary causes should be suspected in patients, in four types of patients. Number one, if the hypertension is seen in patients aging less than 30 years of age, young age hypertension, early onset hypertension, 30 years of age, less than 30 years of age, and the individual is coming with hypertension, then you should suspect secondary hypertension and you should evaluate for the causes. Second is abrupt onset of hypertension. There was no history of raised PP till now. The patient could have visited the hospitals or clinics for other reasons like fever, diarrhea, or something. At that time, till recently, the patient will not have history of hypertension, but now suddenly he develops hypertension, abrupt onset. Then, in that case, you should suspect secondary hypertension. Third case is severe or resistant hypertension. Severe hypertension is nothing but systolic SBP more than 180 and DBP more than 110. Either one of these, if if is present, if either one of these is present, then that is severe hypertension. And resistant hypertension is when the patient when the patient's BP is above the safety above the target. When the patient BP is above the target, even after receiving three antihypertensive agents, including a diuretic, that is known as hypertension. The patient BP will be above the target value even after using three combination of antihypertensive drugs, which should include a diuretic, that is resistant hypertension. So in patients severe or resistant hypertension, you should suspect secondary hypertension. So you should evaluate for the causes. How you will evaluate? First, you will take history, examination, and then investigations. By these things, you will evaluate the cause of secondary hypertension. The last thing is the disproportionate target organ damage. For example, if patient has a BP of 150 by 100, and you are seeing in fundoscopy changes of severe hypertensive retinopathy. Then this is known as disproportionate target organ damage. So this PP usually shouldn't have severe type of hypertensive retinopathy, or you are seeing in urine routine hematuria and proteinuria, means protein and RBCs are present in the urine. So that is also, that is nothing but these are the signals of target organ damage. But the BP is not so high. This is grade 2, okay, grade 2 hypertension. So it is not expected at this range. So in these type of patients also you should suspect secondary hypertension. These are the four types of patients where you should suspect secondary hypertension. Number one is early onset hypertension, less than 30 years of age. Number two is, what is number two? Number two is abrupt onset hypertension, early onset hypertension, abrupt onset hypertension, severe or resistant hypertension. Each of this terminology has its own definition, okay, which I have discussed just now. And the last one is disproportionate target organ damage. When these four conditions are met, you should suspect secondary hypertension, and you should evaluate for the cause by history, physical examination, and investigations. So as I discussed, the most common cause of secondary hypertension is the renal and renovascular cause. You can remember the causes for secondary hypertension as renovascular cause, number one. Second is endocrine disorders, number two. And number three is other causes. In other causes, only two are there: coarctation of the aorta and obstructive sleep apnea. So let us discuss these one by one. So in renal causes, renal parenchymal disease may be present. Most common cause of renal parenchymal hypertension is diabetic kidney disease. Remember this point. Diabetic kidney disease. In diabetes patients, in old patients, in young patients, or in young patients, the renal parenchymal causes can be glomerulonephritis and polycystic kidney disease. Remember, these are very important causes. Okay, diabetic kidney disease in diabetes patients, and glomerulonephritis or polycystic kidney disease. Okay, so these are the causes. These are the most common secondary causes of hypertension: diabetes, glomerulonephritis, and polycystic kidney disease. So hypertension, both a consequence and driver of the renal injury. So in glomerulonephritis, there could be a history of sore throat in patients. Post streptococcal glomerulonephritis, you can have history of sore throat. Okay, and there can be other features of glomerulonephritis. This is a form of nephritic syndrome. So you can have features of nephritic syndrome. You can have edema also. You can have hypercholesterolemia, and you can have hematuria in these patients. RBCs, dysmorphic RBCs, you can see in microscopic examination of urine. Okay. In polycystic and in history, you can have sore throat or history of some skin disease, after which the patient have developed this hypertension. Polycystic kidney disease, patient, when you palpate the abdomen, you will you can palpate the kidneys. Okay, that sign is there, no? So you can palpate the kidneys. Okay, and if you do the ultrasonography in polycystic kidneys, you will discover that the kidney is polycystic. Polycystic kidney disease, cysts around the kidneys. Okay, so this is how you can diagnose this most common secondary causes of hypertension. So number one, diabetes is not mentioned here, but remember this one. So number one is diabetes. Number two is glomerulonephritis, nothing but nephritic syndrome. Glomerulonephritis. Number three is polycystic kidney disease, PCKD. 1, 2, 3. These are the most common secondary causes of hypertension. Second is the renovascular hypertension. So there is basically obstruction of the arteries which are supplying the obstruction of the renal arteries. Basically, there is obstruction of the renal arteries. That obstruction can be due to atherosclerosis, or that can be due to fibromuscular dysplasia. So this is seen in adults, and this is seen in young patients. Okay, so older patients, widespread vascular disease. How you will suspect vascular hypertension in? So by that history, I said no just now. Severe hypertension, resistant hypertension, abrupt onset hypertension, usually you see in renovascular hypertension. Okay, and disproportionate target organ damage. All these things you will see. So mainly in parenchymal disease, usually presents as abrupt onset of hypertension, and these things, atherosclerosis and fibromyalgia, these present as severe or resistant hypertension. Severe or resistant hypertension. Remember this one. Okay, these can also present like this, and this can also present like this, but basically I'm saying the difference. And one more important point in older patients is, so they will have signs of atherosclerosis in the peripheral arteries also. For example, the patients can have history of intermittent claudication. Intermittent claudication. Patient can have history of coronary artery disease. Okay. Patient can have arcus senilis in the eyes. Arcus senilis. Sorry, arcus. Yes, senilis. Okay. So these are the clues. So widespread vascular disease, Burgers disease. Okay, that is there. So this is a clue. So patient will have widespread vascular disease. So in older patients, you will see this. One important point to differentiate from fibromuscular dysplasia is, so there is involvement of the proximal portion of the renal artery in atherosclerosis, whereas in fibromuscular dysplasia there is involvement of distal portion of the renal artery. And fibromuscular dysplasia is usually seen in a young woman, and in ultrasonography you will have this string of beads appearance. Okay, so diagnostic hint for that. So when you auscultate the abdomen, you will have abdominal bruit. Okay, which will extend from systole into diastole. So continuously, so murmur is which is seen in the heart valves, and bruit is which is seen in the large arteries, and hum is the murmur which is seen in the veins. So murmur is the abnormal sound which is seen in the valves. Bruit is the murmur which is auscultated in the arteries, and hum is the abnormal sound which is heard in veins. Okay, so that means you will hear a bruit in the uh, abdomen. When you auscultate, you will hear a bruit. Okay, so this is 90% specific for the renal artery stenosis. And one more important point in this patient is, which involve the renal artery. If you give AC inhibitor, the hypertension will increase, the BP will increase. Instead of falling, the BP will increase in these patients, these renovascular patients. So this is a very important point, very important clue. So if you prescribe a AC inhibitor or ARB, and if the BP is increasing, then you should suspect there might be some renovascular cause. So to summarize, how you will how you will take history and examination in these patients having the renovascular disease. So patient, if you give AC inhibitor or ARB, then the BP will increase instead of decreasing. Second one is, in older patients, you will have signs of atherosclerosis, other atherosclerosis. Okay, so like for intermittent claudication and peripheral artery disease or coronary artery disease, they will have, and you will okay, those things are there. And in sonography, proximal portion is involved in atherosclerosis, whereas in fibromuscular dysplasia FMD, distal portion of the renal artery is involved, and string of beads appearance you will see. And the other thing important sign which you will see is the abdominal bruit, presence of abdominal bruit will be present, abdominal bruit when you examine. Okay, so these are the findings in these patients. So the most common cause of secondary hypertension is renovascular cause. So coming to the endocrine disorders now. So first and foremost is the primary aldosteronism. So usually the adrenal gland which is present upon the kidney, which has the adrenal cortex and adrenal medulla. So some benign tumors or some hyperplasia of some portion of this gland are responsible for hypertension. That is endocrine disorders. Okay, so primary aldosteronism, also known as Cone syndrome. The thing which happens is, there is increased secretion of aldosterone from the adrenal cortex in these patients. So what will happen? Sodium will increase, potassium will decrease, proton will be lost, there will be alkalosis. Okay, so these signs, and renin will be suppressed. Renin will be suppressed. So these are the signs. So suppressed renin, elevated aldosterone, unprovoked. This is important word. Unprovoked. This point. Unprovoked hypokalemia, meaning there is no vomiting, there is no diarrhea. Still, the patient is having hypokalemia. So Unprovoked hypokalemia is a sign of Cone syndrome, along with increased sodium, decreased renin. But when you suspect this Cone syndrome, you will measure something called as aldosterone by renin ratio. Renin ratio. So by this, you will screen these patients of Cone syndrome, and you will confirm this Cone syndrome by salt loading test. Salt loading test. I think aldosterone renin ratio should be more than some 30, what I remember, 20 to 30. What I remember. Okay. So by aldosterone renin ratio, you should, when you suspect, by seeing the electrolytes, when you suspect, you order renin and aldosterone concentration, and you obtain a ratio. If that ratio is more than that, then you should proceed for confirmatory test. That is salt loading test. Next is the pheochromocytoma. So it is a benign benign tumor, pheochromocytoma of the neural part which is present in the adrenal cortex. Okay. The adrenal cortex, remember, cortex and medulla. In medulla, there is the neural part. So from the neural part, there is excessive secretion of catecholamines, adrenaline and noradrenaline. This is the cortex. Okay. If this is the adrenal cortex, so this is known as the adrenal cortex, and this is known as the adrenal medulla. So medulla is usually composed of the neurons. Okay. So these will secrete catecholamines, meaning adrenaline and noradrenaline. So when there is hyperplasia, or when there is increased, or when there is benign tumor in this portion, there will be excessive secretion of adrenaline and noradrenaline. Okay. Because of that, what will happen? A rapid large dose secretion of this catecholamine produces episodic triad of headache. Produces episodic triad of headache, palpitations, and sweating. Triad of headache, palpitation, and sweating. Why this is episodic? Because there is episodic large concentration release of these catecholamines into the blood. At that time, the patient will have headache, facial flushing, vomiting, palpitations, and sweating. So episodic presence of these things, headache, palpitations, and sweating. Headache, palpitation, sweating. If the patient gives history that I have the history of episodes of these three things, then you should suspect pheochromocytoma and the patient has hypertension. One more important point is BP is fluctuating in these patients. Fluctuating BP will be there. Fluctuating BP, meaning when there is no episode, BP will be maybe some 140/90. But when there is episode, BP will go to 180/110, like that. So this fluctuation will be present. Fluctuating BP will see in pheochromocytoma. So these are all the clues to see pheochromocytoma. So how do you diagnose? You will order plasma-free metanephrines or plasma-free catecholamine levels or 24-hour urine metanephrines. If they are increased, then you diagnose pheochromocytoma. And one more thing is, you do just ultrasonography or CT scan. This also give clue about pheochromocytoma. Okay, it is a chromaffin cell tumor secreting catecholamines. That is the second thing. Okay. The third important thing is the Cushing syndrome. How do you suspect Cushing syndrome? So first, see the patient. Patient will be having a Cushing-like habitus. The body weight of the patient may be increased. Patient may be fatty looking. Patient will be obese. Okay, patient will be obese patient. So, and the patient may have hypertension. So in these patients, patient may have those abdominal streaks and buffalo hump. Okay, and buffalo hump and broad neck, moon-like face. All these features may be present. Okay, if you suspect this thing in patient, then you screen with 24-hour urine free cortisol. Here in pheochromocytoma, you will diagnose with plasma-free catecholamines or plasma-free metanephrines or 24-hour urine metanephrines. Whereas you screen here with 24-hour urine free cortisol or overnight dexamethasone suppression test. This is the very important test. Overnight, ONDT, it is called as overnight dexamethasone suppression test. Okay, overnight dexamethasone suppression test. So that's how you diagnose Cushing syndrome. Okay. Then other things, coarctation of the aorta. So you will have radiofemoral delay. So whenever you are seeing a hypertensive patient for the first time, you should measure the BP of all the four limbs: right limb, left limb, upper limb, and right lower limb and left lower limb. If the SBP is higher in the arms than the legs, then you should suspect coarctation. And if there is radiofemoral delay, you are palpating the radial artery with femoral artery, and you appreciate radiofemoral delay, and this is in pulse and this is in BP, and you see SBP is high in arms then legs, then you should suspect narrowing of coarctation is the narrowing. So narrowing of the aorta distal to the left subclavian artery. Okay. So radiofemoral delay and more SBP in upper limbs compared to the lower limbs. This is the clue to diagnosis. Okay. Next thing is drugs, obstructive sleep apnea, which is commonly seen in patients who are obese and who have fragmented sleep. So this fragmented sleep, what it will do, it will cause intermittent, because of intermittent hypoxia which will develop in these patients due to obstructive sleep apnea, patient having enlarged tonsils, patient having enlarged adrenal glands, or patient who are very much obese. Okay, so those patients will have intermittent hypoxia during the sleep time. Why? Because during sleep time the respiratory drive is decreased, so they will experience hypoxia at that time. So because of that, they will suddenly wake up from the sleep. That this will cause, this intermittent hypoxia will cause sympathetic activation. So this sympathetic activation is responsible for hypertension in these patients. So main problem in these patients, obese patients, or patients having the respiratory obstructive sleep apnea, it can be upper respiratory tract or lower, like asthma patients or COPD patients, they also have hypoxia during night times. Okay, they also, so there also there is sympathetic activation. So 50% of patients who are having obstructive sleep apnea, they will have hypertension. Okay, so you should see the patient whether the patient is obese, or you should see the tonsils, whether there is nasal obstruction, deviated nasal septum, or some turbinate hypertrophy, or enlargement of the adrenal gland, or there can be history of asthma, chronic asthma, or history of COPD. So all these patients have obstructive sleep apnea. Okay. Okay. Next is drug induced. So oral contraceptives when used for long time will give birth to hypertension. And SAIDs, what they will do, they decrease the prostaglandins. Remember, prostaglandins relax the blood vessel. Okay, relax the blood vessel, relax the efferent arteriole. Prostaglandins in the kidney, they relax the efferent arteriole. So, and by thus they cause less damage to the glomerulus. So when you use NSAIDs, they will inhibit the prostaglandins, and efferent arteriole will be narrowed, and the pressure in the glomerulus will be increased. So because of that, there will be glomerular injury and hypertension. So NSAID when used for long time, or corticosteroids when used for long time, the patient will develop hypertension. So the patient who are using corticosteroids for long time in long dose, so they will develop a Cushingoid-like status, Cushingoid appearance. Okay, this is a clue for corticosteroids. NSAIDs will cause decreased prostaglandins and increased sodium retention. Other thing is erythropoietin. So in patient with polycythemia vera, so who are having hemoglobin 20, HB of 20, 19, and when you measure the erythropoietin concentration, it is increased, and there is no secondary causes. There secondary causes are ruled out. For example, secondary causes like patient is not taking erythropoietin from the external source, or the patient is not having any hypoxic states which are responsible for increased erythropoietin. So when the secondary causes for erythropoietin, increased erythropoietin are ruled out, and erythropoietin is increased, and further if you see, if there is Janus kinase JAK2 mutation is there, so then the polycythemia vera is diagnosed, and in these patients also develop hypertension. And calcineurin inhibitors, for example, in patient tertiary hyperthyroidism, for example, in patient CKD, you use this calcineurin inhibitors. No, sorry, I'm very sorry. So calcineurin inhibitors, these are other drugs. So calcineurin inhibitors, so they also are responsible for hypertension. Okay, remember, oral contraceptives commonly used, NSAIDs commonly used, corticosteroids commonly used. Okay, these are commonly used drugs. So these are responsible for hypertension. Erythropoietin and calcineurin inhibitors, like tacrolimus. Example for this is tacrolimus. So these also cause hypertension. Okay, this is about in detail about the secondary causes of hypertension. Just to summarize this, so most common secondary cause is the renovascular cause. In renal, diabetic kidney disease, diabetic or nephritic syndrome, or polycystic kidney disease. So history, physical examination, then investigation. In renovascular cause, atherosclerosis, fibromuscular dysplasia. Okay, again history, physical examination, and investigation. Endocrine disorders, first and foremost, you should rule out Cone syndrome, aldosterone renin ratio, and salt loading test. Pheochromocytoma, plasma Phe metanephrines or 24 urine metanephrines. Cushing syndrome, again 24 urine cortisol levels or overnight dexamethasone test. Other causes include number 1, coarctation of aorta, number 2, obstructive sleep apnea, and number 3 is drug induced. Coarctation of aorta, obstructive sleep apnea, and drug induced. Coarctation of the aorta, obstructive sleep apnea, and drug induced. So important thing in obstructive sleep apnea is fragmented sleep. Okay, or any patient who is having chronic hypoxic condition. Okay, coarctation of aorta. So I said when you see a new hypertensive patient, you should measure the BP in all the 4 limbs and you should see the pulse, radiofemoral pulse. So there you can diagnose this thing. So that's all about the causes of secondary hypertension. Most common cause is this renovascular cause. Okay. Now coming to the clinical management. So in clinical management, so by just we will discuss about the modalities of measurement, threshold discrepancies, meaning how do you measure a patient coming to you, how do you measure the BP, and which threshold you should use in that patient. So just we'll discuss this thing in the next video. We'll discuss the investigations, initial investigations and secondary investigations, and the risk score, other different types of risk score for assessing the cardiovascular risk, and then uh, uh, how to give hypertensive drugs, meaning pharmacological treatment and lifestyle advice. Okay, this we will give. If time permits, we will discuss more things also. Okay, so modalities of treatment. The office effect is nothing but the BP you measure, the patient has come to your in your clinic. The BP is more in the clinic, but in home it is normal. So that is office effect or white coat phenomena necessitates the use of out of office monitoring for accurate diagnosis. So if the patient has 150 by 90 or some you say 140 by 90 BP, so just you say the patient to measure the BP in home morning and evening, and the cutoff in home BP monitoring or ambulatory home BP monitoring is 135 by 85. It is 5 mmHg less. Okay, so multiple times if the patient is getting this type of BP, then hypertension is diagnosed. Or else if this is not possible, patient is not able to measure the BP in his home, you just this is very important. Okay, you just say the patient you just measure the BP in your clinic. If it goes, I said when to use 130 by 80 and when to use 140 by 90 as threshold. So patient who are elderly aged, for example more than 50 years of age, and comorbidities, patient with comorbidities, you should use this threshold. And patient who are less than 50 years of age without any comorbidities, you should use this threshold in your clinic. Okay, so one time you see the patient comes and you see the BP and any one of these threshold is met. Okay, first what you do, you make the patient to sit down for 10 minutes. Okay, relax for 10 minutes, then you measure the BP in both arms. If it is reaching these thresholds, then you say the patient to come in the next visit. For example, in the first visit only, if you are getting the BP as more than 180 systolic or diastolic more than 110 mmHg, then there itself you should investigate the patient and start the antihypertensive drug. So this is multiple measurements are there when the BP is less than 180 systolic and less than 110. But if the patient is having at the time of visit only, the patient is BP is like equal to 180 systolic or equal to or more than diastolic 110 BP, at that time only you should send the investigations and uh, start the antihypertensive drugs as suitable. Okay, but if it is less than 180 systolic and less than 110 diastolic, then you should you say the patient to you take measure the BP 2 to 3 visits of your clinic. If there is persistent elevation in the BP, then you start the antihypertensive drugs with lifestyle advice. Okay, this is how you will measure the BP. And one more important point in measuring the BP, at each visit you should measure the BP twice. Now when you measure the BP twice, so in two readings, if you are getting a difference of 10 mmHg in diastolic BP or 5 mmHg in 10 mmHg in systolic BP or 10 mmHg difference more than 10 or more than 5 in diastolic BP, then again you should measure the BP. Again, you should measure the BP, and you should take the last two BP measurements, those last two BP measurements who are having less than 10 mmHg systolic BP difference or less than 5 mmHg diastolic BP difference. Till that time you should go on measuring. Okay, so the difference between two measurements should be less than 10 diastolic and less than 10 5 sorry, 10 systolic and less than 5 diastolic. Then you should take the average of those two readings. If the average of those two readings is more than the threshold, then you should say the patient, if the hypertension is not severe, to come on the second and third visit. And if and similarly you will measure the BP as I said now. And if the patient is getting persistently elevated BP, then you investigate the patient and you start the antihypertensive drugs along with lifestyle advice. So this is how you will measure this is very important. Okay, so some patient is coming and in the first visit he is having 140 by 90, you will just start the antihypertensive drug. This is not the method of giving hypertension. This is very common practice. This has become very common practice today now. So this is not the procedure. This is not the procedure according to the standard books. The procedure is that which I have discussed now in 5 minutes. I have taken 5 minutes to describe this procedure. Okay, so this is very important. Okay. So if office effect white coat hypertension is there, okay, so you should take the office BP as I said. If the patient is able to get the home BP measurements, then that is okay. That is more preferred. Okay, if the patient if it is not possible, then you take the decision based upon the office BP only. Automated office blood pressure performed while the patient is unattended significantly reduces the white coat response and provide readings that correlate more closely with 24-hour ambulatory monitoring. Nothing but the patient has the BP monitor for 24 hours, and that will record the BP for 24 hours, and that will give the average for each day. So that is nothing but home BP or automated blood pressure monitoring. So if most of the time that is not possible, so most of the physicians take the decision on the office BP only, because we are in underdeveloped developing country like India, and in India also many in rural areas they will not have this opportunity to measure this home BP. So you take the decision on the office BP only. But the gold standard is automated home BP measurement. Okay. So something has happened wrong. Okay. So as I said, when you are taking the decision based upon the office or clinic BP, you will follow either this threshold or either this threshold. When you should use this threshold and when you should use this threshold, I have already discussed. Okay. If you are taking decision based upon home BP monitoring, then the threshold is this much, 135 by 85. Okay. Multiple visits, at least 2 visits. The book says at least 2. So 2 to 3 readings is enough. So Davidson says there should be a gap of 1 week in 2 visits, or you can take consequently also. So at least 24 hours gap you should give, and then you take multiple visit BP average. Okay, 24-hour ambulatory mean BP, that is the patient will have that automatic BP measuring machine. So based upon that the threshold is 130. Remember, so ambulatory mean BP, the patient is working and doing all his things and his BP is getting recorded in the machine. So but the cutoff for that is still lower, that is 130 by 80. And for home BP it is 135 by 85, but cutoff for ambulatory BP is 130 by 80. And one more important point, in home BP, when the patient is awake, the BP should be, the threshold is 135 by 85, and when the patient is sleeping, for example in night time, the BP should be, the threshold is again lowered, 120 by 70. Okay, ambulatory nighttime threshold. So this is also very important. When the patient is measuring the BP in his home, tell the attenders of that patient, so to mention whether it was measured while the patient was awake or during daytime, or when it is measured during nighttime, or when the patient is sleeping. So depending upon that you will take the decision. Okay, 135 by 85 is during morning time when the patient is awake, 120 by 70 is during night time when the patient is sleeping. Okay. So these things you should exclude while you are measuring the BP. White coat hypertension, so elevated office BP but normal home or ambulatory readings. So there is intermediate cardiovascular risk associated with white coat hypertension. Okay, between normal and sustained hypertension. So you can say white coat hypertension is like pre-diabetes. Okay, pre-diabetes. It is a pre-hypertensive So the risk is equivalent to the pre-hypertensive patients. Okay, but there is high risk of progression to sustained hypertension. That's why nowadays books like McMaster says that if the white coat, there is persistent white coat hypertension, then you should start the antihypertensive drugs. Next is masked hypertension. This is opposite to office BP. There is normal office BP but elevated out of office readings. The risk is similar to sustained hypertension. So the risk is more than white coat hypertension in the masked hypertension. Okay, and the prevalence is also more. See, 10 to 30% prevalence, and it is often linked to obstructive sleep apnea, patient who are smoking, and patient having metabolic syndrome. Patient having metabolic syndrome. So masked hypertension, where you see masked hypertension, you see in patient with obstructive sleep apnea, in patient who smoke, and metabolic syndrome, and prevalence is more than the white coat hypertension, and risk is also more than the white coat hypertension, equivalent to sustained hypertension. That means the patient who has BP, same risk these patients have. Okay, one more thing is pseudo hypertension. This is seen in elderly with severe arterial calcification, also known as Moncke-Burke's sclerosis. If you have read in pathology, this was there. Cuff fails to compress the artery because the wall of the artery is stiffened. So the cuff fails to compress the artery, and you will measure high BP. This is seen in elderly. Suspected when radial pulse remains palpable despite cuff inflation above the SBP. When you suspect, you will suspect this pseudo hypertension when the radial pulse remains palpable, means it is pulsating, radial pulse is pulsating even after the cuff is when the cuff is inflated above the systolic BP. This is known as Osler's maneuver to diagnose pseudo hypertension. Okay, so these are the three kinds of white coat hypertension, masked hypertension, which is seen in obstructive sleep apnea, smokers, and metabolic syndrome, more dangerous than the white coat hypertension. This has intermediate risk, this has high risk, this is high risk, this is intermediate risk. Okay, this is pseudo hypertension. So in both these cases, you should have you should prescribe antihypertensive drugs. If this is persistent, you should prescribe. And if mass hypertension, then definitely you should use the antihypertensive drugs. So that's all. That's enough for today, and the time is also more. We will discuss other things, management part, in the next class. Thank you.